orders for giving me this opportunity to give this very important topic. My names are Dr. Martin Chikwanka, or you can call me Major Martin Chikwanka. I work in the Zambia Air Force. I've been working in the public health sector for the past 15 years now. Initially, I was a clinical officer, then I upgraded to a medical officer. So I hold a fellowship in endoscopic retrograde cholangiopancreatography, endoscopic ultrasound, and the advanced endoscopy, as well as the master's in endoscopic oncology. I've worked for Maina Soko Medical Center for the past, I think, 10 years, and now I'm at UTH finishing up my internship. So I hope this topic will be very interactive. Feel free to participate. Feel free to ask any questions where we are not clear. So just like the heading has said, today we are going to deal with endoscopic ultrasound. Though it's not really much available in our public health institutions here in Zambia, but it's coming slowly because most of the operations now are being done endoscopically. So you find that in some of the advanced countries now, the only open surgery they are doing is just a cesarean section. These other operations they are doing, and they are using endoscopic approaches. So my scope of representation will touch on I will touch on the introduction, the types of probes that are used in endoscopic ultrasound, the indications for endoscopic ultrasound, then also some of the contrasts that we can use in ultrasound, general ultrasound or endoscopic ultrasound, how we prepare our patients. And so I'll look at the procedure and then I'll summarize, then we'll have questions and answer session. So basically, endoscopic ultrasound, it combines two very important topics. It combines gastrointestinal endoscopy procedures, the knowledge. It also combines the knowledge of sonography. So I presume most of our members in this group have the knowledge in sonography, but now we are going to combine endoscopy and sonography on how we are going to approach certain lesions that can occur in the body. So endoscopy can be in any part of the body, but the one I'm going to discuss today, it's just touching on gastrointestinal endoscopy, meaning that both upper gastrointestinal endoscopy and lower gastrointestinal endoscopy, and combine the two topics. So when you look at the picture that I've projected, on our left, that is a lower part of the esophagus. We have a swelling down there. So when we are doing upper gastrointestinal endoscopy, we have no means of collecting a biopsy, which will give us a definitive conclusion in this case. Therefore, there is need for another technique that we can use to enter this region and collect a biopsy, for example. That is now the endoscopic ultrasound that we are looking at on our right side of the screen. So it's showing the region clearly, and we can apply color Doppler and get a biopsy using the needles that are specialized in doing this task. So basically, just like I've said, endoscopic ultrasound, it is integrating endoscopic exploration and ultrasound images to assist us to come up with a diagnosis, to assist us to give treatment to our patients, and to look at structures that are below the mucosa of the gastrointestinal system. In this case, we can look at the left part of the liver, we can look at the gallbladder, we can look at the spleen, we can look at the pancreas, we can look at the kidney. Mind you, most of us sonographers have a challenge in imaging the pancreas because of abdominal gas, or we can have intestinal loops that are obstructing our image. So it becomes very tricky. But when you do the scanning from the inside of the gastrointestinal system, specifically the stomach, you're able to see a clearer picture like I'm going to show you. So we can also do vascular studies. We can even collect samples from the blood system. We can also give treatment using endoscopic ultrasound. So in endoscopic ultrasound, there are basically two types of transducers that are used. There's what we call the linear probe and the radial probe. And the difference I'll explain as I go on. In terms of their frequency, it ranges from 7.5 to 20. So from time immemorial, we have been performing in our various hospitals, which is very common, transcutaneous ultrasound. But sometimes, like I've given an example of the pancreas, we may have poor visualization because of abdominal gas. So we need another mode of imaging, which will give us a clearer picture. So this endoscopic ultrasound now, it gives the answer to that concern that we have. If we're not able to get a clear image of the pancreas, we can approach it endoscopically and get clearer images. So in this case now, we have discovered that technology has combined endoscopy and the knowledge of ultrasound to visualize certain structures better. In this case, like the pancreas, we can visualize the gallbladder, we can visualize the common bowel duct. So endoscopic ultrasound compared to conventional ultrasound, it gives a better resolution because it's closer to the structures that we are imaging. So since it's closer to the structures that we are imaging, we can also use it to classify certain lesions of the gastrointestinal system. Things like the gastrointestinal stromal tumors, we can classify them using endoscopic ultrasound. I try to incorporate a video here. I hope it will be able to show. It's just a small video, but it seems let's see if it will play. Okay, we can see it at the end.
Dr. Martin, are you there? It's not playing yet, I think. I don't know if it's on my side only.
I'm trying to load the page. I'm having challenges with network. I'll try to skip it so that it doesn't take our time.
Okay.
bit slow, but I'm trying to recover. I hope we're able to see my picture now.
Yes, type of systems.
Okay, thank you very much. Sorry about that. Yeah, so the type of transducers that we use in endoscopic ultrasound, there are three. There's a sectorial system, the radio system, and the mini probe system. But the common ones, the most common is the sectorial system. The radio system also is being used here and there, but the probe system, because it's very small and it can even go into the common bowel duct, and we can do ultrasound from the common bowel duct or the hepatic ducts, but it's quite expensive and very few institutions have access to this probe. So that leaves the two, the sectorial probe and the radio probe. The sectorial probe, it takes images from 100 to 180 degrees. Then the radio probe, it takes images at 360 degrees, like this, the way the CT scan takes the images, like the picture is showing. So on our left side, at our far left, that's the sectorial system. That's the one we are seeing at our far left here. So the angle of imaging, it's between 100 and 180. Then the radio probe is 360. I'll show you the images, how it looks like. So this is a curved linear, the sectorial probe. It's just like the design is just like the way the transducer we use for abdominal ultrasound is designed, except that this one is at the tip. It's at the tip of the endoscope. The endoscope has a long cord, which we are able to insert into the gastrointestinal system and image from the inside. So this probe is usually found at the end. So the good part with endoscopic ultrasound is that we are able to do various procedures. Like we can see a needle at the end here, which we can use either to inject drugs or either to get specimens, or we can use it to insert a stent. We can do all sorts of procedures with this instrument channel that it has here. Then we can also see the camera system and the light, which is here. So there's a camera and the light which will direct us when we are entering the gastrointestinal system. I'll share a video at the end of hopefully to be able to show so that it makes more sense about what I'm trying to say. So this is a radio probe. Around here, this is where you find the piezoelectric crystals here, where we are going to project our images, and it gives us the feedback. So it takes pictures, as you can see, it's around the end of the endoscope. So it will take pictures at 360 degrees. This is the same one we are able to see here. So the endoscope has a handle, which we are seeing here, which we are going to operate using our hands, either to move the probe to the left or to the right, or up and down. This tip of the endoscope, we are able to move it and get the images that we require. So on our right side of the screen, that's the image we are going to get. Like I mentioned earlier, the radio probe, it gives us images at 360 degrees angle. So the circle we are seeing in the center here, that's our transducer. Then around here, the dark thing here, we are seeing it's air. Then this structures we are seeing here are the layers of the gastrointestinal tract. So we're able to see that we are getting an image at 360 degrees. So the indications of endoscopic ultrasound, to start with, we want to get, because we enter through the mouth, the throat, the upper esophagus, the middle esophagus, going down into the stomach, then going to the first part of the duodenum and the second part of the duodenum. That's how far we are going to go. And in these places where we are passing, we can image structures beneath the layers of the gastrointestinal tract. So this includes the images of, the structures that we find in the mediastinum. So we can also use it to assess the mediastinal lymph nodes. We can also use it to image the pancreas and surrounding structures. There are certain gallstones that are tiny and we are not able to pick them with conventional ultrasound. Using endoscopic ultrasound, we are able to pick those stones. So endoscopic ultrasound, usually because you are closer to the mucosa of the gastrointestinal tract, it will give you a very good resolution of the structures that are beneath there, and we're able to see them properly. Endoscopic ultrasound can also be used to do fine needle aspiration cytology. We can go into the thyroid, we can go into the mediastinum, like I've said. We can go into the pancreas, we can go into the liver, we can go in any structure that is around the gastrointestinal tract and do whatever imaging that we would want. We can also use it to drain things like the pancreatic pseudocysts. We can drain them. We can drain hepatic abscesses. We can drain them. We can literally any structure that is closer to the gastrointestinal system, we're able to enter it with our endoscopic ultrasound and do whatever procedures we feel. We can do stenting. We can also deliver chemotherapy. Like we can have a pancreatic adenocarcinoma. We can use endoscopic ultrasound to go directly to the adenocarcinoma and inject chemotherapy there. Sometimes this chemotherapy is in form of beads, which you can inject there directly and not taking it through the mouth and using these other routes. I'll show you the pictures how these procedures are done. Like I've mentioned, we can do stent insertions, we can do liver biopsy, we can do fiducial placements. Fiducials are small metallic objects that we use when we are giving radiotherapy to our patients. For example, you may have a patient with a pancreatic adenocarcinoma who are on radiotherapy. And we know radiotherapy can injure the normal cells. It can injure the normal organs. So these fiducials, what we do is we can use endoscopic ultrasound and insert them exactly where the adenocarcinoma is, so that when the radiotherapy is being given, we are just targeting that lesion and not any other structure. So these are the uses of the fiducials, which I'm going to show you later on. Then we are also going to use endoscopic ultrasound by performing what we call neurolysis of the celiac plexus. There are patients like those with pancreatic adenocarcinoma or pancreatic cancer, which is very difficult to manage these days. And they are suffering from pain that is not responding from the painkillers and everything. So we can insert a needle into the celiac plexus and inject maybe 95% alcohol there and alleviate that pain. So these, you can use it in gastrointestinal stromal tumors, the pancreatic neuroendocrine tumors, hepatocellular carcinomas, and insulinomas. Those which are in those patients who are in the variation stage, we can kill that pain. Or in terms of treatment, what we call ablation. we can inject ethanol there with a strength of 95% and try to treat that tumor. Contrast. So endoscopic ultrasound incorporates contrast, just like we do with the CT scans and MRIs. As we can see from our pictures there on my left, the picture looks a bit blurry, but when we inject contrast on our right, we're able to see that picture. So this is an adenocarcinoma we're seeing. So the commercially available contrast, we call it Sonove, though it's a bit on the expensive side. So when we use it, we are able to highlight a lesion and localize it. So like I've mentioned earlier, we can inject a needle there and give abrasion therapy, or we can inject the fiducials there and give the radiotherapy. All sorts of interventions, we're able to use it. So in this case, we are using it to visualize this lesion. So basically, this is just a pictorial view of how we insert the endoscope. So at the tip, we've got a transducer. At the tip here, we've got a transducer, which we are going to use to get images. This is a code that we are going to use to insert the endoscope. Then at the beginning of the scope, there are those wheels that we saw. These wheels, which we are going to manipulate using our hands to take us in whichever direction that we want to go. So in this case, we are in the stomach. So just like in the direction the scope is pointing, so we're able to visualize all the structures underneath there. We can see the pancreatic duct. We can see the walls of the stomach. We're able to visualize even structures around that. So that's just a picture to illustrate how it looks like. So like we have seen the angle there. I mentioned that it can take Are you able to get me?
Yes, we can hear you. Loud
Okay.
and clear.
So as you can see, there are some light there. So it gives us an angle of the images that we are going to pick on our screen. So we can move this instrument forward, we can move backwards, clockwise, counterclockwise, and study the structures that we want. So imaging in endoscopic ultrasound, it's staged in 3 stages. So, or stations. So in this case, we are in the stomach. Our endoscope is in the stomach. So this is what we call stage 1. Hello? Okay. So in this case, where whatever images are covered by the light there, we are able to see them. This is the first station. The second station is the first part of the duodenum, this side. So in this level, at this stage, we are able to see the head of the pancreas, depending on which direction we have directed our transducer, or we are able to see the gallbladder, this side, or the common bowel duct, or the ampulla of Vata. Then the second part of the duodenum also, it will give you a nice pictures, meaning that we're able to image the pancreas at different angles. This picture, basically, it's just showing you how now we are combining the 2 procedures like endoscopy, sonography. Then we get the pictures that we want. This is showing us the scope in the first part of the duodenum, which is station number 2. So this is showing us the picture that we are going to see endoscopically. And this one is showing us the picture that we are going to get when the sono pictures. So this one, the transducer that we are using is the radio transducer. Basically, On our far left, we are seeing the transducer there, and it's showing us the pictures that we are going to see. This one now, we are using the sectorial probe. So we're able to see at this level, when we reach station number 2, we are going to get the common bowel duct. You are going to also get the pancreatic duct. We can even measure them. Then we're even able to get the pancreatic tissue here. This is the pancreas. So we're able to visualize it clearly as compared to when we are doing the conventional ultrasound. Then on top, we're able to see the structures that we are going to visualize in terms of the blood vessel. So we have the superior mesenteric vein, we have got the pancreatic duct, we have the portal vein, we have got the splenic vein. All these are the acoustic windows that you are going to use if you want to clearly visualize the pancreatic duct as well as the pancreas. So in this case, we can even measure the pancreatic duct and come up with whatever things that we are trying to investigate. So basically, these are just the pictures that we are going to pick when we are now. This is a third station. And look at the direction where the transducer is pointing. It's pointing this side towards the pancreas. And down there, we have the ultrasound image where we are going to pick the ampulla alvata. We are going to pick the common bowel duct here. We are going to pick the pancreatic duct. We are going to pick the aorta. We are also going to pick the inferior vena cava. So in case there are lesions there, we're able to pick them. This is just there to demonstrate the images that we are going to get. This is the same thing, except now we have gone anti-clockwise now. We have shown our transducer towards the liver, so we're able to get the gallbladder, we're able to get the left side of the liver. This was the image that we saw before. Then this picture demonstrates what we are going to be seeing when we are in the esophagus. When we are doing endoscopy, conventional endoscopy, we push in air because the organs are collapsed. So we push in air so that we distend them and we can see clearly. But when we are doing endoscopic ultrasound, we do the opposite. We suck out air. Remember, air is an enemy to the sonographer. It disturbs a lot of images. So we are going to suck out the endoscope itself. It has a mechanism of sucking out the air, and you get clearer image. As you can see in this transducer, first of all, we have got reverberation artifacts here, and we've got air around here. So we make sure that we suck air as much as possible so that we just remain with these structures that we are seeing around the gastrointestinal tract. This image, because earlier I mentioned that we can approach the gastrointestinal system from the upper gastrointestinal system or the lower one. So the upper one, we call it a gastroscopy. The lower one, we call it a colonoscopy. In this case, we are approaching from the anus, going up. So we have seen, we've seen our transducer here and the images that we get. So this image that is hypoechoic here, it's the prostate. So the fact that we're able to visualize a structure like this, it means we can get biopsies, we can give treatment. Remember, I talked about ablation therapy. If there is a lesion here, we can give chemotherapy. If there's an abscess anywhere around this area, we can drain it, because endoscopic ultrasound encompasses therapeutic procedures as well. So basically, we can do anything with a scope. Nowadays, we're even able to replace heart valves using an endoscope without operating on the patient. That's how far technology has gone. So earlier on, I spoke about the neurolysis of the celiac plexus. The celiac plexus, we may not be able to see it on the ultrasound image, but we target the origin of the celiac trunk. So that's where we find the celiac plexus around here. So we'll push a needle from this angle and inject 90%, 95% or 99% alcohol in this patient who has been experiencing excruciating chronic pain, which is not responding to painkillers. So we inject alcohol there and we'll take away the pain just around this area and around that area. Of course, when you are trying to capture this picture on the screen, we'll apply color Doppler so that we're not injecting in the blood vessels. Are we together, or maybe I have questions up to this level?
We're together. Maybe we could take the questions at the end, sir. Maybe so if people have questions in the house, they can just take note of them. Then at the end we can, yeah. Thank you.
These are the fiducials that we use. Remember, I said when a patient is about to undergo a radiotherapy, I gave example of a pancreas, it could be the liver, it could be the lungs. When they want to give radiotherapy, we want to avoid radiation going towards healthy tissue. So we want to mark, actually we are just using them as markers. So the endoscope it has a provision of having a needle which we can use to insert these markers into that region and leave them there. Then we are giving an oncologist some boundary in which to shine their radiation as they give treatment to their patients. So those ones which are common on the market, we call it the Lumicoil, which is being produced by Boston Scientific. Most of our consumables that we're using, they are being produced by Boston Scientific, though they are on the expensive side. So these are part of the fiducials that we are going to insert. This is just an example of how we insert them. Here I've used the fluoroscope on our left here so that we are seeing the direction where we are going. And as you can see, there's a needle. There's a needle at the end of our transducer here, which we are going to use to insert them. Then on our right, there are arrow marks there where they have been inserted. This hypoechogenic area, this one, it's an adenocarcinoma. So you insert them there, and that gives guidance to people that are giving radiation to this patient that you're supposed to direct it in that area. I spoke of neurolysis when you want to take away the pain. On the right of the screen, there is a shiny, which is a shiny strip-like thing structure there. That is a needle. So the ultrasound needle, we inject it there, then we attach a syringe containing 95% alcohol and inject there. That's like we are seeing on the left side of the screen. That's how the needle comes out, and that's how we inject into the celiac plexus. Celiac plexus. This picture is demonstrating how we do a liver biopsy. Light shiny thing we are seeing. First of all, this is our transducer. Then the needle comes at that angle. That's a beauty about endoscopic ultrasound, because you're able to visualize the needle as it is coming out of the scope. And as you are imaging, you're able to see the needle in front of you. And you're able to see, actually, as you are doing procedures, you're even seeing what you are doing. This picture is just showing us the the sectorial probe, then this structure, this we are seeing, this lesion we are seeing is an adenocarcinoma, so we can even classify how we can classify it, how far it's going into the surrounding structures. So the picture at the far left, that is a gastrointestinal stromal tumor. Like I mentioned from my preamble, that when we are doing conventional endoscopy, we are supposed to get a biopsy here, but our forceps are just able to get the mucosa. Now this mucosa, it's normal, it looks normal, so we're not able to get inside this lesion. So when we apply endoscopic ultrasound, there's a picture in the middle here. So we're able to see clearly the lesion and how far it's going. Then, other than that, we're able to push in a needle and get some biopsy for analysis. That's a beauty that endoscopic ultrasound has brought. So for me, when I'm doing endoscopy, just endoscopy, this is what I'm going to see. You're going to see, yes, there's a growth, but what can we do about it? Even if we send a patient for a CT scan, yes, they'll tell us there's a lesion, but we need to confirm the diagnosis. We need to get a sample from this lesion, which we are not able to do with just endoscopy. So when you incorporate endoscopic ultrasound, then we're able to classify it. Then we're also able to get the specimen. As it can be seen from our right side of the screen, the image is clear here and how far the lesion is going. This is the same thing, a gastrointestinal stromal tumor. Come just from explaining, this is a sectorial probe that we have. Same thing, we have a lesion in the esophagus. As you can see, it's covered by normal mucosa. So we are not able to do much. We will just report that we have seen this lesion, but we are not able to get the biopsy and able to classify it. So when you look at the picture on the far right, you're able to see it clearly when you apply ultrasound. We combine both now. The knowledge of ultrasound, we combine it with the knowledge of endoscopy. We're able to classify it and how far it's going. We're able to even tell if we can remove this lesion. So there's a treatment modality we call endoscopic mucosal resection and this endoscopic submucosal resection. We're able to remove this endoscopically, depending on which layer it's going deeper. So as you can see, this mass, this patient may not even need chemotherapy. We can go in endoscopically and cut it out. There are certain consumables that we use and have this thing cut out. But looking at currently the situation we are in, like in Zambia here, very few patients have access to facilities like the endoscopy I'm talking about, like the endoscopic ultrasound I'm talking about. These are the people usually sent to for chemotherapy or radiotherapy because they are not having access to endoscopic ultrasound and just basic endoscopy. But now, because technology has advanced, we are trying to come up with the better treatment modalities where this can be, we can cut out this endoscopically and just start following up patients. So when we remove this, we review them at 3 months and at 6 months, at 1 year, we continue following up so that they don't have a recurrence. So like I mentioned earlier, endoscopic ultrasound, we can use it to insert stents. Like these ones are different types of duodenal stents. Imagine a patient has a cancer of the head of the pancreas and the duodenum is blocked. So we're able to push in this stent so that we open, food can pass from the stomach to the small intestine. So for patients with the gastric outlet obstruction, I have given an example of cancer of the head of the pancreas. Let me see if I can see an image. So if this patient, for example, they have a blockage here, a partial blockage here, we can push in a stent here and open up so that things can pass. We usually use this approach when you are giving palliative care, those patients with advanced cancers. So we can insert these stents. The same applies to patients with pancreatic pseudocysts. We can create a fistula between the stomach and the pancreas and drain the cyst using a stent, but there are different stents that we can use, not these ones. These ones are for the duodenum. These are the colonic stents. So if there's a partial blockage in the colon, we can still use it as a way of palliative care, or there are patients who refuse to undergo surgery. So as a temporal measure, we may want to push in a stent there so that contents can pass. Except that sometimes we may have complications like these stents can migrate or they can dislodge. So we may need to put another one. And these stents are quite expensive. So it becomes stressing on the part of the patient. But when it's done by people who are specialized in stent insertion, usually it shouldn't be a problem because we're able to suture it to the wall of the colon. So basically, in terms of patient preparation, we do endoscopic ultrasound under light sedation. How long it takes, it depends on what you are trying to do. For example, if you are inserting a stent, it may take longer. If you're just doing maybe classifying a lesion, usually it takes less time. For drainage of cysts, we might need to put the patient on an antibiotic. If you are doing the translectal endoscopic ultrasound, we usually give the patients an enema, which will give them diarrhea, so that the lumen of the colon is clear, so that we can visualize it and it doesn't give us disturbances in terms of the images that we are going to get. Sedation usually is not required for these patients because even the probe is quite small in diameter. So the imaging procedures, like I mentioned earlier, we can either use the radio probe or the sectorial probe. So now the difference between these two, the disadvantage with the radio probe, you can't do procedures like I was mentioning, injecting all those stent insertions. You're not able to, because it doesn't have an instrument channel. But this one, the sectorial, it has an instrument channel like I showed you. So this one is a radio probe. It doesn't have an instrument channel. It gets these pictures at like a CT scan, but it doesn't have therapeutic options here. So that's a disadvantage. So most people prefer to use this one because it has an instrument port. Here we can push in a cannula, we can put a needle, we can put all sorts of instruments. Even when we are doing endoscopic mucosal resection, we can push in something like a snare here and we apply the therapeutic approaches. This now, that's why it's loved by a lot of people because of this extra ability, because we're able to do procedures. But this other one, like this, we are not able to. That's a difference between these two. So that's why most people prefer a sectorial probe. So in order to successfully do endoscopic ultrasound, the knowledge of endoscopy should be applied. You cannot do endoscopic ultrasound without the knowledge of endoscopy. So the next image is just the images that you are going to get when you, like I mentioned, you start from the upper esophagus. What you are going to come across is the left atrium, and the ascending thoracic aorta and the pulmonary trunk. These are the transesophageal echo images that you are going to get. You can apply color Doppler. You can do all sorts of things with the probe because it has the ability to also do echo for the heart. So as you go down, you continue getting images. You get a clearer image of the mitral valve. This is the left atrium, and the left ventricle now comes into view. Now it's like you are swallowing a bolus of food. We are going down as you are pushing the probe down or the endoscope down. These are the images that we are going to get. So the acoustic window that we are going to use is descending thoracic aorta. Basically, let me just say the aorta. You follow it until where it gives off the celiac trunk. Around those structures, that's why we are even going to visualize the pancreas, beta, and all these other structures. So this is the aorta. Now it gives off a celiac trunk. Mind you, the sectorial probe, it gets images parallel to the axis of the endoscope. So we're just following the aorta. So around here now, we'll start visualizing structures like the pancreas. It means we are even closer to the duodenum. So when we rotate the scope either clockwise or counterclockwise, we're able to see the left lobe of the liver. So like I said, when you find the celiac trunk, then you look around that area, you're able to see structures around the pancreas. So when you look at these images on my top right, this is a very good view of the pancreas. Our probe is there, and you see it's closer to the mucosa, so you're able to see nicely all the structures around the pancreas. So you see that there's a slight difference with the images that we get when you are doing a transabdominal ultrasound in as far as the pancreas is concerned. So basically all these images are explaining one thing. Those are the structures you are going to see depending on which angle you place your probe. So this is a spleen. So we are going to visualize it from when we are in the stomach. This image is showing a cyst in the pancreas. Now we are aspirating. Now we are now applying therapeutic procedures. So like I said, we can drain a cyst from the pancreas, or we can create a fistula so that whatever contents that are in this cyst, they drain into the stomach. So like in this case, this is a fluid that was aspirated from the cyst. This is abrasion therapy. This picture is just giving us a pictorial view of how we can give abrasion therapy. There's a needle going into the lesion. Like I said, for example, you can inject alcohol there, you can inject chemotherapy there. So we are just going directly into the lesion as compared to this chemotherapy we are giving. Maybe the patient is taking orally or is given IV with all sorts of side effects. But for this one, we are just going directly into the lesion. It's either we ablate the lesion or we put fiducials there so that as they are giving radiotherapy, we are just targeting a diseased structure. It's basically just showing the image, a good image of the pancreatic pseudocyst. This now is the image we get when we are in station number 2. These are gallstones from the gallbladder. Like I said, we are able to remove some of the tumors endoscopically. So this, on my far left, there's this growth which was in the rectal area. So we can use a snare it has a loop which we can use to grasp this lesion and apply a current. Then it will be cut off from the mucosa. On my far right, this is what you get after doing that. Then in the middle, this is an ultrasound image you get after visualizing this image, this lesion with a probe. So on my far right, usually for me, what I do, I don't leave it open like this. We have a means of suturing. We oppose the ends of this lesion so that we don't have bleeding at the end of the day. Because this patient can present with maybe delayed bleeding. So usually we can suture, just like we suture the wound outside the body, but inside we can also suture it endoscopically. We have what we call the hemoclips that we can use to close this wound. So this is one of now the good applications of endoscopic ultrasound. You see a lesion, you can remove it. So this person doesn't need to undergo chemotherapy or radiotherapy. You just keep on following them up. This now, it's a stent. On my far right, it's a stent that we inserted going into the gallbladder. This patient had a stone in the neck of the gallbladder. So the gallbladder was distended and it was causing a lot of pain. So we used endoscopic ultrasound to create a fistula between the gallbladder and the stomach, because this stent, we call it, it can oppose the two ends. The mucosa of the gallbladder and the mucosa of the stomach, they can be brought together, then you create a drain from the gallbladder into the stomach. Then from the stomach now, contents will start going through the pyloric opening here towards the duodenum. So this is also one of the applications of endoscopic ultrasound. We can drain the gallbladder, or we can put a stent in the common bile duct and drain the contents. For example, for those who have ascending cholangitis, which is a very serious condition, we can put a stent so that things can drain. So this is a needle that we use for in endoscopic ultrasound. So this needle, it has a handle. This whole thing we are seeing is a handle. So the way we operate it, it sucks, because we use it for a biopsy. It sucks contents of a lesion by capillary action. So when you move this handle down, it sucks. When you move this green handle down, it sucks, just like that. I'll show you. I have a sample here, which I can use to demonstrate. So that's where my presentation ends, unless there are questions or additions or subtractions. It's over to you, Madam Towera.
Thank you so much for the presentation. It's been beautiful. Personally, I've learned a number of things. So I think we can open now the question and answer session. So if you have a question, please just raise your hand. We'll give you an opportunity to ask your question. And maybe, so just maybe whilst people are still thinking, I got a question yesterday. Somebody was asking me, who is licensed to do this examination? Can sonographers, can radiographers do this?
Okay, that's a very nice question. So like I mentioned earlier, I've done a master's in endoscopic ultrasound. I consulted some people from HPCZ, so they didn't give a clear